All right, I think we're all set, Dr. Bradley.
All right. Good morning, everyone. We're going to go ahead and call the meeting to order at 9 a.m. Just a few housekeeping items. This meeting is being recorded. Anything that is said in the meeting will be kept forever on the YouTube channel that the ADHS has. So just keep your mics on mute if possible, as well as your cameras off if you do not want anything shared. If you are on by phone, you may have to hit *6 to unmute yourself if you'd like to speak. I'll go ahead and do a roll call, Shelley.
Andrew Tang.
Present.
Anthony Griffey. I think he just joined. Brent Brigette. He was on.
I saw him on a few minutes ago.
Charles Hu.
Present.
Chris DeChant.
Present.
Cliff Jones. I thought Cliff was on. Cliff, you might need to hit *6. David Notrita. Debbie Johnston.
Present.
Franco Castro Marin.
Present.
Gail Bradley.
Present.
Garth Gamer. Herman Butler. Simon Pfizerfan.
I'm
Judy
present.
Baum.
Yeah, hi, I'm present.
Oh, thank you.
Yeah, thank you.
Judy Baum.
Present.
Melissa Anderson. Thought she was on.
Present.
Oh, thank you. Neil Williamson. Nurav Patel.
Present.
Bill Johnson. Rod Reed.
I am present.
Thank you, Rod. Sandy Nygaard. I thought Sandy was on. Nope. Sharon McDonough. Did Sharon drop off?
This is Sharon. I'm present.
Oh, thank you. Sean Bowker.
Present.
Tara Johnson.
Present.
And Vicki Bennett.
Present.
I count 18. We have quorum.
Excellent. Thank you very much, Shelley.
This is Tony Griffey out in Kayenta. I'm here.
Thank you, Tony.
All right. Thank you, everyone. Anyone who we did not capture your name, just send a message in the chat to let us know you're here, or you can email Shelley as well so we can capture your attendance for today's meeting. In your packet for today, there is a copy of the attendance packet. Just a reminder that in the bylaws, we do have an attendance requirement to be a participant on staff. We do contact individuals who are not meeting that requirement to ensure that they will participate. So just a reminder that that is in your packet as well. I believe we just had 2 more members that joined us, Shelley.
Oh, thank you.
Dr. Gamer and Neil Williamson.
All right.
Next, vacancies. We do not have any vacancies at this time. We'd like to welcome a new member, Dr. Charles Hu. Welcome to staff. So thank you for participating in the meeting today. And we also have 2 reappointments as well. Reappointments for this cycle are Dr. Patel and Dr. Tang. So thank you all for being on the meeting today.
Gail, I think one of the members might have an announcement.
All right, go ahead.
Sharon, did you have an announcement? maybe I was mistaken.
Hello, are you guys able to hear me?
Yes.
Oh, yes.
Yes, you can. I'm sorry, I'm having a hard time hearing.
Yes, ma'am. Go ahead.
Okay, all righty. I just wanted to let the group know that I have been given a different assignment here with the city. I'm currently the director over the 911 center, and as such, I will be giving up my seat on this group, on this board, and will be recommending Deputy Chief Brian Stevens from the Tucson Fire Department to fill my spot.
Thank you, Sharon. It's been a pleasure to have you on the committee for several years with your participation. So good luck with your new position.
Thank you very much. I appreciate it. And I appreciate my time here as well. I've learned a lot of things listening in to all these experts. So I appreciate it. Thank you.
Thank you. All right. And Dr. Jones, we see your attendance as well. Thank you very much. All right. Next, we definitely want to recognize two big events this month, especially for this committee. This is Trauma Awareness Month, and this week is also EMS Week. We have a couple in your attachment, as well as what Shelley is being displaying right now. So this is just some of our trauma data that was shared, and also our EMS Week flyers. So those are both in your meeting packets and being displayed as well. What Shelley is sharing here is our 2020 Arizona EMS System Snapshot. This is something that Julia Vinton started putting together for the Bureau based on our data. I think it was 2019's data was the first year that we did this. And so this really takes into account all of the data that we collect. And it's got significant information and really a nice single sheet snapshot of what our EMS system looks like in Arizona. Shelley, I don't know if you can maybe scroll to the top, and then we'll kind of just go down from there. So as you can see, we had a little over 1 million EMS incidents in Arizona for the 2020 year. In the analysis for this, we included 888,000. There's different things that may result in incidents being taken out from that. We have 166 EMS agencies that submitted their data. There's a breakdown for ground and air, and it talks about the number of average number of EMS incidents reported to the state per day. You can see here we've got some traumatic injury numbers as well. So 13% of all the calls are traumatic injuries. And some median time intervals for incidents as well. So just a really nice snapshot. We will continue to produce these annually. So like I said, this is our second year around doing this, but we will continue with these snapshots. So this is for our kind of overall EMS system one. And then do you have the trauma snapshot?
Yeah, just a sec.
Thank you.
All right, can you see the trauma one?
Yes, perfect. Thank you so much. So as you see here, we have the breakdown of the trauma system. We have a map of where all the trauma centers are in Arizona. We have the total number of trauma centers, the level 1 pediatric, level 3, as well as level 4 centers. Breakdown in terms of trauma incidents as well. The top 6 mechanism of injuries, I think no surprise to most people, falls are number 1. And then we also have a breakdown of intent of injury. The pediatric incidents, you'll see the little teddy bear there. That's just over 6,200 or approximately 10%. And then also median injury to emergency department arrival time, a breakdown comparing urban to rural. And then some other factors, risk and protective factors highlighted in the bottom of this as well. And I believe this is a new snapshot that was put together this year. Is that correct?
No, it's from 2020 as well.
Okay.
Hey, Gail, this is Andy. Just a question for pediatrics. Are we using less than 18 as the cutoff, or are we using 14 and less as the American College of Surgeons defines?
Vatzel, I believe you are on the line there. I saw she is our data expert, so I will make sure that the right answer is given with this. I believe for this data analysis, This is simply less than 18 as kind of a pediatric patient. Vatsala or Anne, are you on the line to answer that question for Dr. Tang? She may have stepped away. We'll touch base with her and get an answer to you before the end of the meeting, Andy, but I'm pretty sure this is less than 18, but we'll get a definite answer for that.
I appreciate it. Thank you, Gail.
Mm-hmm. Any other questions on that? I think it's a nice snapshot and summary kind of our whole trauma system, and these are available on our website as well. All right, hearing no further questions, I just wanted to make everyone aware we had mentioned at the last meeting that the National Association of State EMS Officials, or NASEMSO, was going to be close to finalizing the Model EMS Clinical Guideline version 3 update. Those were published in March of 2022 and have gone live. The reason for the delay was they actually wanted to include the updated ACS field triage, which we are going to discuss later today. So because of the time frame of those overlapping a little bit, NASEMSO wanted to hold back until they could get approval to include the final updated field triage guidelines. And so those were included in the final version. PMD has started the process of updating our state TTTGs based on the NASEMSO model EMS guidelines. The hope is to actually get that updated by the end of the year. So we're going to look forward to some input from this group as to how we want to proceed with the updated ACS field triage guidelines moving forward. Any questions regarding that? All right, I will hand it over to Chief Garcia for the Bureau Chief report.
You guys are welcome to move up.
All right. Good morning, Dr. Bradley, and good morning, staff board members, and especially the folks that we this morning. It's really nice to see your faces here at the Adams Building downtown. This is Bureau of EMS and Trauma System. It's really nice to meet some of these folks face to face for the first time today. As Gail said, this month we are honoring Trauma Awareness Month as well as EMS Week. And during our EMS Council meeting a little bit later today, we will be highlighting that have been put together for both EMS and trauma workers.
Rachel, sorry to interrupt. We cannot
make sure that we're recognizing that, self-care, resiliency, mental health are so important, and especially this month when we honor the workers on the front line, that we make sure that those resources are available. We'll be going
Rachel, we can't hear you at all for the audio.
Oh, is that right?
Yes, sorry.
Gail, if I hold it a little bit closer, is this any better?
That is better, yes. I think you have to be pretty close to those mics to be heard.
Okay. Well, we are on a phone today, so apologies for the audio, but
I think here now.
Okay, I won't repeat everything that I just shared, but I'll just say that we will be circulating more EMS and trauma resiliency resources that have been compiled through this group, as well as the other statutory committees that we'll meet today. Thank you again all for the work that you do. The quick updates that I will share this morning are along the lines of legislative and rule updates. The Department of Health Services has been tracking a handful of bills this legislative session that are related to EMS. If there are any questions for the department, certainly we're happy to talk through any questions that stakeholders may have. The Bureau is not, or the department is not sponsoring any legislation this session, so we do not have a position on any of the bills making their way through the House or Senate at this time. But again, if stakeholders have any questions or concerns at this time, please let us know. In terms of rule updates, we do have the new air ambulance rules that will go into effect June 5th. We've been meeting with the air ambulance providers to talk through some of the changes and what to expect when we hit June this next month. There is a provision in the new air ambulance rules that will require air providers to work with hospitals and stakeholders to notify them when they are terminating operations. Overall, I think the rules package that was put together over the last several years is very strong, and we'll continue to meet with stakeholders as we get ready for that implementation next month. There is one other rulemaking that is ongoing right now related to ground ambulance rules. That information is available on our department website if anybody has any questions on that topic. And I'm sure that we'll be having some more conversations about additional potential rulemaking moving forward, including scope of practice and potentially some of our other areas of administrative code. Overall, I think that those are the high notes in terms of legislative and rule updates. In the last month, the department did host a trauma program managers and medical director workshop. It was well attended, and I think it was pretty well received. If stakeholders continue to feel like that's a good resource and use of time, certainly the Bureau will look forward to hosting more workshops like that. We really want to thank you all for your participation. It's really great to be able to bring folks together for meetings like this, and we'll look forward to more opportunities to have some spin-off workshops, work groups as we move forward. Gail, I think that that's all I have for now. We're still struggling with the audio in this room. I'm going to hand this phone back to Shelley so she has control of the audio. And if Vatsal, you're on, we will turn it to you next.
Good morning, everyone. I'm going to share my screen. Is that okay, Shelley?
Yeah.
So the cardiac arrest incidents, we are tracking them over the months and by years. So as you see, in the month of April, the number of cardiac arrest cases have slightly increased compared to what it was last year. But it's the pattern remains same, compared to other years, not much difference. Then the cardiac arrest dispositions, what we observed in April, are slightly higher death, like from 60% to 63.9%. And the same thing can be reflected if we see in the transport has decreased and number of deaths at scene has increased in the month of April. And we saw the same pattern in the February month, March, and then the April. For the opioid, just give me a second, I have to go to 2 sets of database. Okay, opioid incidents, then the month we had 754 cases of opioid overdose observed in the AZPS database. Sorry, all right, okay. Number of deaths, there were total, 6% of deaths in April of all the cases of opioid overdose, 6% death, and 73% were transported to the hospital, slight decrease than the last year. We are also planning to develop a dashboard which gives you monthly and weekly data on cardiac arrest and some of the major primary impressions in the EMS world, like cardiac arrest or opioid, STEMI, stroke, and those kind of informations available on our website. So we are in the process, almost at the end of the process of developing that dashboard. So pretty soon, just say that would be available for public to see it on a weekly basis, how many cases are happening in the state of Arizona for each of these primary impressions. That's about it. Any question?
Can we ask Vatsal about Dr. Chang's question? Hey, Vatsal. Dr. Chang had a question on the pediatric data on that snapshot for trauma. Can you confirm the age of pediatric for that info slide, please?
Yes, let me confirm it is now. Let me just in my program check, it is 14 or 18. But give me 5 minutes and I will get back to you guys on that.
I believe Kara put in the chat box that it was 0 to 17.
Yeah. Who put it there?
This is Kara from Phoenix Children's. I just referenced the pediatric EMS 2020 snapshot that you all provided us. In that report, you listed out pediatric patient as 0 to 17 years.
Okay,
So
yeah,
I made the assumption you did the same in that report.
Right. If it, yeah, I just wanted to check. I was going to check in the same place. So yes, perfect.
Thank you, Kara.
Thank you, Voxel, for sharing that data. Next, on to our standing committee reports. Sean, for the TEPI report.
Good morning. Can everybody hear me?
Yes, we can. Thank you.
Okay. TEPI met on March 16th, and the meeting minutes were approved. We did note that we have 2 vacancies on the committee, one for an air ambulance premier EMS agency quality improvement officer, and the other vacancy for a state level 4 trauma program manager. Anybody interested, please send your resumes in.
Hey, Sean.
Yes.
Sean, it's Shelley. We did fill that air ambulance role.
Excellent.
Barbara stole it.
And then we discussed the discretionary reports, and we noted that no reports have been produced since the list was launched several years ago. Indeed, the list is really too broad in reality to do anything with it. So we voted to remove the list as a standing item, but we'll keep it as a reference for future reports. We also discussed the anticipated end of the emergency declaration, sunsetting waivers, and crisis standards of care, and encouraged agencies to have discussions with their medical directors. We then discussed data, current data reports, the opioid report, and then the trauma report, with a noted limitation on the trauma data with regard to falls. As it stands with ground level hip fractures, those are not included in the trauma data. So the fall data is very limited. And that's related to the state's trauma inclusion criteria, which is set in rule and cannot be changed until we open the rules again. There is a difference between that data and the National Trauma Data Bank series, because ground level fall hip fractures are included in the National Trauma Data Bank, but they are not included in the state's data unless that patient was transferred to another facility. We also discussed our trauma annual report and the next round of reports, and we suggested dividing the data into different level trauma centers as well as rural versus metro. And we even further discussed looking at the differences in the level 4 centers and their capabilities. Then we adjourned the meeting, and our next meeting is July 21st.
All right, thank you very much. Next is Sandy on the line for an education committee update.
I don't think she is.
Okay.
So I have the draft minutes here. I'll read a brief report. The March meeting of the Education Committee, the public body approved the minutes. They approved a training for maternal resuscitation and interventions, and that has been placed on the website. They also approved the naloxone for pediatric patients training. They formed a work group to create training curriculums for STRs. They formed a work group to look at trainings that have been posted and we're at that 2- and 3-year mark for needing review. TJ McKay discussed the impacts of NREMT ALS redesign and distributive education limits. Rachel discussed the emergency declaration and things that were happening with that being sunsetted. And then Travis discussed training and workforce survey. That's all.
Thank you, Shelley. Next, Dr. Casper for PMD update.
Thank you very much. So for the PMD update, we had met on March 17th at noon. We received our bureau update. We had our vacancy report, which includes a position for Southeastern Regional Representative. Received our various bureau updates, including updates for naloxone leave behind and the new AZDHS opioid website. We got an update from Shares and EMS for Children. As far as discussion and action items, we discussed the EMCT scope of practice, which again is currently on moratorium, as has been mentioned several times. We did discuss a pilot program as it relates to ultrasound guided IV placement by paramedics in a hospital setting. We discussed other hospital-based paramedic practice items, including either generating a work group or having a specific permanent agenda item on PMD to address this growing, expanding area of paramedic practice. We received an update from Chief Garcia and Dr. Bradley regarding the collaborative patient offload plan between EMS providers and hospitals, which at this point has been widely adopted, and that information has been widely dispersed. We approved a motion to form a T3G work group, which has now been formed, and those work groups have been assigned their materials currently under review. And we also took time to discuss the sunsetting emergency declaration. And that's all I have.
All right, thank you. Next up, Kara for Trauma Managers Work Group.
Good morning, everyone. So our trauma program manager work group met virtually at our last meeting, but part of our discussion is that we are going to get back on track with meeting in person. So we are all very excited about getting that back. Part of our big discussion the last time was about our new trauma listserv resources that are available to all of us trauma programs through the University of Arizona. So we had a really thorough discussion about what is available, how folks can post what they're utilizing at their institutions, and then how it can be used across all levels of trauma centers. We have not decided on our next upcoming meeting yet, because like I said, we are moving it to in-person, but we're still meeting on a quarterly basis. And that's all we have.
All right, sounds good. Thank you very much. Next, Adam Rodriguez for PACES update.
Good morning. Just a couple updates. We also met on March 17th. We have no vacancies at this time. Our pediatric naloxone training, as was aforementioned, is now live on our education and independent study website. Right now, PACES is fielding 2 work groups, one for behavioral health, and the ask is for volunteers for either one of these, and one is for pediatric behavioral health, which is it seems to be pretty complex, and so we could use as much expertise as we can get. So we'll take volunteers in that work group, as well as we are also looking at training gaps for EMCTs. We're trying to identify some areas where we think that would be beneficial for additional training. If either one of those work groups sounds good to you, we would love to have you as a volunteer. Otherwise, our next PACES meeting meets on July 21st. And that's all I got for PACES.
All right. Thank you very much, Adam. Next, for discussion and action items, Shelley, if you please share the meeting minutes from January 20th. And if I can get a motion to discuss, amend, and approve the staff meeting minutes from January 20th, 2022. I will need a first and a second.
So moved. This is Sean.
Thank you, Sean. Thank you, Andy. All right, the minutes are in your packets and also displayed here. Any recommended amendments to the minutes? Hearing none. In the best format for a virtual meeting, anyone opposed to the meeting minutes as displayed, please say aye. Or sorry, nay, sorry. Please say nay. Any abstentions? All those in favor, please say aye.
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 All All right, thank you. Meeting minutes are approved. Next item is a discussion item to discuss the burn disaster triage and follow-up from the Arizona Coalition for Healthcare Emergency Response disaster drill. Dr. Foster. Dr. Foster, are you on the line right now? Since we don't hear him on the line right now, we will go ahead and keep moving along the agenda. Next for the standing item for the ACS Cody and Trauma update, Dr. Patel.
Good morning, everybody. A couple of updates regarding the verification process with ACS. As you're all aware, the resource manual now is moving to its new color, the gray, slate, whatever you want to call it. That has now been released. It is on the webpage, so you should all be able to access that. You'll also notice that the entire format has changed as compared to the 2014 resource manual, and it's now really following the taxonomy that the other programs in the American College of Surgeons use, especially oncology. So it's now very concise. The segments are all made so there's no duplication. If you remember the old book, the same thing would appear in 4 different chapters. It may have different words to it. So it's all been consolidated and really been put into categories that address the clinical, the operational, the administrative, quality. So hopefully it should be very clear to follow and be able to really get the information you need regarding the category you're looking at. So that book has been released. Currently, starting later this year, probably in June or July, there will be some emails going out to folks about the administrative platform, the education that's going to go around this process. And currently, and again, these are subject to change, but for the consults that are occurring on the current 2014 resource document, those will probably sunset in August of 2022. And the consults will then go on a hiatus and probably restart in February of 23 by the new standards. Again, some of this is subject to change, so none of this is in stone, but it gives you guys a guideline for anyone who's coming up on consults. For verification, the new process is currently slated to go live in September of 23. For focus visits, the sunset for focus visits will occur in August of 24, with the new process then kicking in a month later. So this will give everyone enough time who needs a focus visit, but were done on the 2014 resource document to get those done under the same criteria. So you didn't have a focus and now you're held to a completely different standard than your initial visit that generated the focus. So they've taken into account the timelines. They've given people enough time to accommodate for them. There are going to be forums for FAQs, for questions. So all of that will be coming through the ACS COT committee. So it'll all be coming by email, also be on the webpage. So kind of use that as your source of truth. All the information will be there. And to the delight of a lot, including those of us who are reviewers, it's gone from 387 standards to 112. So they've really taken a lot of those standards and made them meaningful. As opposed to multiple duplications that occurred in the other chapters. So hopefully this really does make the process a lot simpler. It makes it a lot more clearer. So a lot of the shades of gray that kept coming up in the past will be corrected. The rollout of the process, and there'll be more information on this, the initial lead reviewers as the new resource manual rolls out will actually be folks who were part of writing the manual. So what the college is going to try to do is to really have the subject matter experts be the lead reviewers. So if there are questions, there are clarifications, they're actually being answered by those who actually participated in the process of doing that. And the last update is there's been a lot of requests coming through from level 4 centers for some guidance. So, this manual is pretty much the 1, 2, and 3s. So the COT is setting up a subgroup that's going to actually start looking at level 4s and decide what direction to take. So that feedback has been noted, and there is a subcommittee that will be set up around that.
All right, thank you very much. Any questions for Dr. Patel? All right. Next, we have a discussion and action item for discuss, amend, and approve the ACS field triage updates. If I can get a motion in a second, and then I can give a little bit of background on this.
Motion, Franco.
Thank you.
Second, Vicki.
Thank you, Vicki. All right, so if you can go ahead and open the first attachment in this section, Shelley, to give a little bit of background on this. In 2011, when these were last updated and published, STAB did actually approve the ACS/CDC field triage guidelines, and there was quite a big state initiative to get this out across the state to all the trauma centers, emergency departments, as well as EMS agencies and EMS personnel. I actually found a couple of the laminated pocket guides that were printed by the state that had the endorsement of STAB at the bottom of those that were actually given out to many providers throughout the state. And so this is the updated version for those who have not seen this. This has come out pretty recently with the new updated field triage guidelines for EMS. The ask for this committee is hopefully people have seen this already, but if not, I really wanted to take some time to review this, get feedback, and then also see if this is something that STAB would like to endorse. If that does occur, we would move this forward to PMD as well as MDC to make the final recommendation as to whether these get adopted into the state triage treatment and transport guidelines. So that is a little bit of the background on this. If you could scroll to the top, Shelley, to the red section. So just wanted to kind of display this and start getting some feedback from the group. I think as we look at this, many of the items in the injury pattern are things that we kind of recognize are there in our current ones. There are some changes that are kind of more specifically listed here. You'll see active bleeding requiring a tourniquet or wound packing with continuous pressure. That is new verbiage compared to the current version. You'll see under mental status and vital signs for all patients, the GCS has now been updated to simply being a motor score. So it has removed the eyes and verbal and really simplified this to a motor score. Very specifically, can the patient follow commands or not? With the recognition that if a patient is unable to follow commands, you have a relatively good idea of where they are from a GCS perspective. The respiratory rate, I believe, is unchanged. It does specify respiratory distress or need for respiratory support. And then you can see the blood pressure criteria is much more specific than in the current version and really does take into account some specific factors for the geriatric patient population. So I will kind of stop speaking and try to get some feedback from this group. Really, for this committee, this is our opportunity to really help guide the trauma system in the state. And so I hope that we will take some time today to review this.
Hey, Dr. Bradley, this is Andy. I think with the GCS, it makes very good sense. You know, of the three components of the GCS, the motor score is certainly the most powerful prognostic indicator. And the other two are, you know, a lot more subjected to, you know, other factors other than a brain injury. Like someone got socked in the face and have a swollen eye, you know, it's not fair to take off points because they can't open their eye, for example. But the motor score is certainly shown through literature that is as the most important component, and I'm in full support of focusing on the motor score for the GCS.
Thank you.
Dr. Bradley, it's Vicki. I just want to make a comment when we educate. I think everyone on this committee is aware of it, but as we educate some of our medics, nurses, and so forth, when we're looking at the motor score, that is a cognitive calculation. It is not, for say, someone that's paralyzed, their inability to move is a different understanding. So this is, again, related to cognitive if they're unable to move.
Thank you, Vicki. Great point. Any thoughts from any? I know we've got some pediatric center representation here in terms of kind of the vital sign, and then also from anyone who takes care of a lot of geriatric patients. Any thoughts on some of these changes here?
No, Dr. Bradley, you actually had met with Dr. Notrika previously when we had thought that these were going out, but he and I both thought that these were great updates and changes.
Thank you, Kara. All right, so kind of looking at this again, obviously the format is very different than the current format that we have, but this essentially is step 1 and step 2, which would then point the patient to the highest level trauma center within the system, kind of with the caveat of geographic constraints. So we can scroll down to the yellow criteria next. You can see here, this is kind of our boxes 3 and 4, essentially from the current version. So box 3, or the mechanism of injury, you will see that there are some specific changes here. It much more specifically mentions pediatric patients unrestrained or in an unsecured child safety seat. So it's more specific for pediatric patients who are not properly secured in a vehicle. You will also see that they have changed the fall from height. So this is now fall from height greater than 10 feet for all ages. So that is quite a big change from what the current format is. Just a reminder, the current version is adults greater than 20 feet and for children greater than 10 feet or 2 to 3 times the height of the child. So this has been simplified to essentially read fall from height greater than 10 feet for all ages. Any questions or comments on that section, the mechanism of injury? You will see why I will break this up into different sections here. I think the last box will be a little bit more controversial. I think those are some good updates and changes into the mechanism of injury section. All right, hearing none, we will go to the EMS judgment section. So this is a section that is labeled differently than the current version. On the current version, this is kind of our step 4, and it's really looking for any special patient or system considerations. This has been labeled a little bit differently in this version, and it's under EMS judgment, and then it really says consider risk factors, and it lists off a variety of things. So it does talk about lower level falls in young children, or adults greater than 65 with significant head impact. So kind of recognizing that geriatric patients with head injury, anticoagulant use, suspicion of child abuse, special resource, healthcare needs, pregnancy greater than 20 weeks, burn in conjunction with trauma. And then it does say children should be triaged preferentially to pediatric capable centers. And then in bold, kind of at the bottom, if concerned, take to a trauma center. So per the ACS update, they're saying that the yellow criteria who do not meet red should be preferably transferred to a trauma center as available within the geographic constraints of the regional trauma system, need not be the highest level trauma center. So that does match what's currently in boxes 3 and 4. So wanted to kind of open that up for discussion. I think one of the changes, some of these special criteria were there. The old version said anticoagulants and bleeding disorder, and then specified underneath that patients with head injury at high risk for rapid deterioration. So this is a little bit more broad. It just states anticoagulant use. So wanted to get some thoughts from the group under this section.
Gail, I'd be, very interested to hear what the other folks online think. But one of the, the largest proportion of trauma mechanisms that any of us see is falls, and particularly in the elderly. And a significant number of the elderly are on anticoagulants. And many will present relatively asymptomatically, but with a head bleed on scan. So I think, to me, the fact that, the anticoagulant is so prevalently used makes me feel like it should be taken a little more seriously. Not that it's not taken seriously, I'm trying to phrase it properly, but I think it should be given a little more weight in terms of triaging. We've had people die from a ground level fall because they had been hyper, super therapeutic on Coumadin. So I think it's something that I would like to give a little more weight to. I'm not sure how to do so in a fair, fashion, and so that's why I would love to hear what other people think.
Hey, Gail, it's Nur. I think, Andy, you bring up a very good point. And I maybe kind of look at it on the other side of capacity, resources, and volume, right? And the more complicated we make things, the more we start getting more resource intensive. I think the more of a risk we run to not being able to meet the standard of the bar. And so I think, and again, not speaking from an EMS perspective, but from a standpoint of keep it simple, right? For our folks who are out in the field who are juggling 20 other different things, keep it simple. And then I would say, let our data then drive our decisions, right? So set a template out, but let's have a structure that we can then somehow, working with Vatsal and the group at the state, actually start capturing the data, track it, and then to your point, Andy, things will flush out, right? That seem to have a higher weight, that need to be given more consideration. But maybe do a run on it, right? This has been endorsed not just by EMS, it's been endorsed by ACS, multiple other national organizations. Maybe we get around this with our own data and keep bringing it back to this committee or to our EMS committee to really evaluate it based on the information we have. It's just food for thought.
Thank you.
So this is Debbie with ASHA. I'm going to give a patient perspective on this because 6 months ago, I'm over 60 and I did have a fall, and EMS chose not to transport me or suggested that it wasn't necessary. I had to call EMS back the next day to take me to the hospital because I had a compression fracture, they found out. I couldn't get up without fainting. And it was in conjunction with a burn. So I don't know really where this leads the conversation, but I think there is education that does need to occur on some of this, whether it's what level of trauma center it goes to, I don't know, but there was something there that EMS missed. And that's it. It's just a patient perspective.
Thank you, Debbie.
This is Charles Hu from Chandler. I just want to mention regarding the top bullet point regarding significant head impact. We have many patients that have minimal head injury externally that have very large bleeds, and they may have room from their in the brain to have these bleeds, but we have found many with large bleeds, significant bleeds that have very minimal external signs of trauma. And the other point I want to make is regarding anticoagulant use. That's kind of broad. Are we talking about, some people think that baby aspirin is not really anticoagulant, but we have found that many patients with head bleeds on baby aspirin. So yes, it's broad. And to Dr. Patel's point, I get it's resource intensive, but I think patients over 65 on anticoagulants are the most vulnerable population. And yes, if you get more specific, then you get to use more resources. But I think that if you want to use that kind of category for judgment call, there's a lot of variations. There are going to be a lot of variations in judgment.
Yeah, and this is Andy. I totally understand Dr. Patel's point. I think this is where, we have to kind of figure out what our threshold is, right? In a resource rich, despite, the fact that we don't feel like we're resource rich at the given moment. And I certainly understand why. And I agree that to a certain extent, we're not. But, relatively speaking, the United States is still a relatively resource rich place to practice medicine, and to what's available in terms of resources. And the ACS, at least with the green book, the orange book, mentions something like 30% over triage. It still falls in within acceptable range, right? And that's because we're practicing in a relatively resource rich environment. Therefore, we have the allowance to over triage, if you will, to avoid the under triage. That's the whole purpose. So the question is, now we're dealing with a aging population, many of whom are on anticoagulants, many of whom will sustain what externally appears to be minor injuries, but have significant intracranial bleed, that have lifelong consequences. And we have received a number, and I'm sure a lot of centers have felt the same, secondary transfers from non-trauma centers that, they find a bleed, and what do? Well, you transfer, and now we're dealing with a secondary transfer, and that can be argued as a resource taxing process in and of itself. I'm not offering solutions. I'm simply bringing up this subject for discussion, and I'd love to hear other people's thoughts. But I think that, to me, with the population that we're dealing with and this aging epidemic, we have to triage carefully.
Dr. Ting, I wonder if this is an opportunity for our larger trauma centers to get together and do our first statewide collaborative and utilize what Dr. Patel mentioned before, our TQIP data, and then also our institution data to drive a change, maybe not just within our state, but also at the ACS level, based on our state collaborative.
Yeah, I think that'd be a great process. There's a part of me that's a little scared about the bureaucracy and how long things take, as we all know. But I think absolutely it's a great opportunity to collaborate. And as far as institutional data, there's plenty of data in the literature. There's an abundance of data in the literature on aging, anticoagulant use, and the increasing morbidity and mortality. We have our own institutional data to support that, but there is an abundance of it in the literature.
This is Franco. I wonder if anybody closer to the ACS decision-making stage can comment on the change of age from 55 back up to 65. I know the literature can be all over the place on this, but my understanding of the literature, it's not just a function of the physiologic changes of age or the proportion of patients who are on blood thinning medications, aspirin, et cetera, but it's also the proportion of patients involved with substance abuse, where you end up having a younger cohort down to 55, ending up in a higher likelihood of significant injury. The 2011 guidelines had 55 and older. That's what Arizona adopted. That's what STAB adopted last time. And now we're back up to 65. And my second comment / question is, to Dr. Bradley, right now the discussion seems to be gravitating more towards, under triage, over triage, kind of where we stand on that. But my understanding is really what the discussion point is does STAB apply a seal of approval to the guidelines as is, or is there not, is there an opportunity to make adjustments? And then my question is, Dr. Bradley, is with STAB's approval or lack thereof, what is tied to that? Does this, if we approve this, does that mean another application of resources for statewide education? Does that mean, edits to standing protocols and changes to in-hospital triage criteria for our trauma center partners? What's attached to our decision today?
So I'll kind of tackle, there were several questions in there. So the first question is really just looking to get some feedback and endorsement of this. This has not been updated or reviewed at a state level since 2011. So it's 11 years since that was done. I think probably most of this committee was not involved with the process back then, just as people normally turn over. So this is still kind of a relatively new process. The trauma system in Arizona has also evolved significantly since the last update. I think in 2011, we had probably half the number of level 1 trauma centers and very few, if any, level 3 and 4 trauma centers at that time. So the trauma centers now, the trauma system now in Arizona has evolved significantly since 2011. I'll tackle probably the easiest component last, which is, are the trauma centers going to adjust their activation criteria? That's something that each trauma center and each trauma system would really need to evaluate of what they're going to do. Certainly, this body is the State Trauma Advisory Board for the state of Arizona. The membership is outlined in statute, and all members are appointed by the director of ADHS. But we cannot tell a trauma center how to necessarily activate traumas within their center. So if this group were to endorse this, I think that would hopefully be assigned to the trauma system as a whole, from both the EMS side as well as the hospital side, that we would like to have a consistent process. Certainly one of the complaints from the EMS side is that if I go to trauma center A, they activate on a ground level fall head injury. If I go to trauma center B, they don't. And so there is some inconsistencies amongst the trauma centers. There's also inconsistencies about anticoagulation. So I think those components all do come into play here. So I think an endorsement from this group, it does not have a regulatory function at all, but it does certainly help guide the system statewide for trauma care. Does that answer your question?
Yes, but the one side that particularly puzzles me is then what would be, because I mean, we do have a little bit more regulatory responsibility to the EMS agencies, perhaps not the trauma centers. So would that, so then would a tacit approval from this body then compel the, EMS agencies to then put out, mass training, republication, editing of, of clinical guideline documents to reflect this new format, et cetera?
So just to clarify, when you say we have a regulatory function, so what I was saying, STAB does not have a regulatory function on EMS or.
All right, thanks for clarifying that, yeah.
Trauma system, yeah. That STAB is not a regulatory body. STAB is kind of a guiding body for the trauma system.
Thank you.
So in regards to whether or not the group were to endorse this, typically most agencies in most regions, when they update their protocols, it's usually on an annual basis. One of the hopes that with the TTG process is to get it updated in time for this to go live for the January 2023 calendar year, recognizing that people would need to do training in the pre-hospital setting for this to go live. So really the discussion and ask for this group is, does this group want to endorse this, recognizing that this is really coming from ACS, as Dr. Patel pointed out. This has been extremely well vetted over a number of years. There's a lot of, the other attachments are all the data that supports these changes and the updates. And if that were to be approved by this group, that would help, I think, guide PMD in the decision on whether or not to adopt that, which would then go to MDC. Again, each regional entity can make their own decision in terms of how they would like to proceed. I see Dr. Gamer has a question. I'm not sure if there's anyone else in the line.
Dr. Bradley, I'm sorry, I've got quite a bit of background noise where I am, so I apologize ahead of time. So you would like a motion to endorse this from STAB at this point?
If that's what the group would like. So that's really, the ask is to really get feedback. This is a pretty substantial change, and this is the first time this has been reviewed in well over a decade. So I want to make sure that we really spend ample time kind of discussing it and making sure the group feels comfortable.
And I understand the next stop for this would be PMD.
Correct. We are going to share this today with EMS Council and MDC just to get some feedback from those two groups as well. And then PMD will be addressing this at the special meeting, and then in June with the final recommendation for the TTTGs in July, with a goal for it to come back for final approval for the update in September meeting. So we're trying to get this out in front of as many different groups as possible so that it's really getting widely circulated.
So if I may, I would like to make a motion to get things rolling here. And I'll explain it later. I move that we endorse the new guidelines with the changes of moving adult age 65 years and older with significant head impact over to mechanism of injury box, and then in the EMS judgment box, anticoagulant use with to include aspirin. And I make those motions because that would take it out of the realm of EMS judgment, which I think would be doing our EMS providers a favor. And then the age-old question is anticoagulants mean aspirin? And that would answer that question as well. So I make that motion on behalf of staff.
Dr. Bradley, it's Nerve.
Yes, go ahead.
A quick question or an alteration to the motion. I think if there isn't a pressing need to have a motion or have this approved by staff today with any of the variances that have been brought up, would it be open to actually putting this out, have people weigh in with their thoughts and the why, and then be able to maybe make this a virtual vote for staff once they've seen the feedback and the input from the stakeholders? Because this is a lot to digest right now, and to give a motion with changes until people start looking at these. And as you look at them and you look at your own programs, there are other things that I guarantee are going to start coming up, and they already have, which is why I'm proposing not, if we don't have to, delaying the motion today until there's feedback, and then maybe doing it in a virtual format.
So we can definitely delay a motion today. We cannot do a virtual vote due to the open meeting laws, unfortunately. We can hold a special session meeting, which we've done for other things that need to get moved forward sooner. So we could certainly hold another special session. We just have to make sure, I think it's 10 to 14 days, Shelley, make sure we don't break any of those rules, that it gets publicized and listed for that. So that would be one opportunity. We can't really do kind of email discussions with committee members because we hit a quorum issue, but we can certainly give people time to gather feedback. In the agenda, there is a number of other attachments from ACS. There's a really nice website that was kind of developed with educational toolkits on how to educate on this, some background and data on how this was developed as well. So those did go out to everyone ahead of time, but I do recognize people often come to the meeting and then we spend more time and they recognize that that information is there. So we can certainly take a motion to table this for now and bring this back, and then we could have a special meeting if the group would like as well. So I kind of heard two things, which is the first was to make an adjustment to this. The second one is to table the motion until a future meeting.
I think technically my motion dies for lack of second, and then the motion to table would take precedence.
Okay. Is there a second to table the initial motion for approval?
Yeah, this is Franco. I'll second it and take this to a vote.
All right. So we've got a second to table. Anyone opposed to tabling this, please say nay. Any abstentions? Oh. Sorry, was that a nay? If you can identify for the record.
Nay, Gamer.
Okay.
Ever the contrarian.
All right. Any other nays? Any abstentions? All those in favor of tabling this motion for now, please say aye.
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 Okay, very good discussions. So I appreciate that we had some good discussion about this. We will definitely would like any feedback that the group has. You can email me directly and I will kind of start collecting that. I will put my email in the chat. We can look to, I think the next meeting is not until September. So we will likely try to reconvene this group here in the next month or two to get some further feedback. If you please take some time to review, there is an item D on your agenda, a number of different attachments, which has all the resource documents from ACS to support this. So that may be helpful as you're kind of navigating this, and also take some time to look at the educational slides. They are very well done, and I think could be beneficial as well. Let me just put my email address in the chat, and then I will move to the next one. All right. So next is a discussion item to discuss the staff annual report and recommendations for data dashboards to monitor healthcare trends and patient outcomes. This is something that we really wanted to get feedback from staff. I think at the last TEPI meeting, Ann and Boxel had shared many of our trauma dashboards that are currently on the ADHS website. And there's a remarkable amount of data which comes from both the EMS run sheets as well as from the trauma center data. And this data can be filtered by region, by age groups, mechanism of injury, and really is a wealth of information. And so one of the things we'd like to consider is how do we potentially utilize that as our annual report or portion of our annual report? The other conversation that we've discussed a little bit is as our trauma centers have evolved, we've done the same type of trauma reports, but we recognize that we now have a large number of level 3 and 4 trauma centers. And do we want to start separating out some of our trauma data that we separate out level 1s in one group and then level 3 and 4 centers in a separate group, recognizing that these are different patient populations often. So wanted to bring that up to this group and get feedback to see if the group was supportive of that.
I think it would be helpful to see the data separated out, but I would say that I would still be interested in seeing the data, whether it's all put together and then separated out as different levels of centers. I think I still would just propose that we still be able to see all of it, whether we separate it or keep it together.
Yes, we would definitely have all the data still as part of the trauma system. So we would absolutely, there just are some sections of the trauma report that may be better suited to have a separation of level 1 versus level 3 and 4s because they're kind of different buckets.
Hey, Dr. Bradley, I completely agree with what Kara said. I think, you know, the type of, the care that we're looking at between 1, 2, 3s and, you know, 4 and 5s are obviously quite different. The lower levels are more focused on ED dwell time, things like that, versus the higher levels are looking at, you know, the whole more comprehensive care of the sick patient. So I do think there's wisdom in separating out because the data that we're looking at is quite different. But it would be nice to also have that perspective across the whole system.
Thank you, Andy.
The only other thing I would say from my review of on the dashboards would be helpful if on the dashboard, so for example, right now I'm clicked on trauma demographics, and the way that we're able to see the trauma rate by age is not the same way that in our snapshots that are provided that we define pediatrics. So I think if we could stay consistent on what that looks like in the reports and what we can see, it would be helpful, at least from a pediatric center perspective.
And Vatsal, are you still on the meeting just to make sure that you captured that to look at for Kara? If not, we'll make sure it's recorded. We'll we'll make sure we do follow up on that. So you're saying the dashboard and the snapshot are two different age breakdowns, is that correct?
Yes, so on the dashboard, it shows it as 0 to 14 and then 15 to 24. And then on the snapshots, the definition of pediatrics was 0 to 17. So I just think consistency on however we're going to show those ages.
Okay, thank you.
Yeah, I think Vatsal, it's Vicki. I think if you can actually find a way to depict it both ways so that it meets the needs of all stakeholders, because you do have some American College of Surgeons that are taking less than 15, and of course, we have our pediatric centers that are considering those ages higher. So I don't know if there's a way to make it so that we can query and get both sets of data just for our own facilities perspective.
Got it. Yes, we will make sure. We'll kind of take a look at that. And some of this may end up just being, that's why I'd asked about the snapshot. The snapshot is a little bit different of a version versus the actual dashboards. You can make some adjustments to look for certain categories. So we could certainly look to see if we could have those breakdowns be a little different as well. So it sounds like there is some support for breaking down, making sure we still look at all trauma data for the state, obviously for all level centers, but definitely some support for separating out level 1 and 2 versus 3 and 4 data. Any other discussion on that? All right, I will move to item F, discuss trauma program manager survey and new trauma registry. Travis.
Good morning, everybody. So Carissa Wilson, our trauma database administrator, shared a survey with the trauma program managers during the last work group to get feedback on changing our registry system in the near future. We only received 12 responses for that. The survey is still open, so I will share a link in the Google meeting chat now. And at this time, I'll pass it over to Carissa to discuss the survey, and she can respond to any questions you may have.
Good morning, everyone. Thank you, Travis. So some of you may know that ESO, who is the vendor for our trauma registry product, Trauma One, will be phasing out Trauma One in the next 3 to 5 years. So ESO has announced that they're going to be offering a new different registry system. And so we're kind of preparing for that, even though 3 to 5 years sounds like a long time. It'll happen fast. So what we've done is created a survey that we can use to get your feedback, because we wanted to make sure that you guys were involved in this process. So the survey just has a few questions that you can go through. It'll take less than 5 minutes, and you can just express any questions or comments or concerns you have with the registry going away and the process and what that's going to look like. We'll probably have a meeting soon just to kind of go over some of those thoughts and questions that you guys have. And as Travis said, he's going to share that, and then you can access it and fill it out. It'll be really quick. Does anyone have any questions? I know that that's really brief, and if you weren't aware that the registry is going away, that's a lot of information taken. But this is just kind of just so you know that this is happening. We want to make sure that we're getting ahead of it and looking at all of the options that we have. Does anyone have any quick questions for me?
Carissa, this is Rachel. I just want to clarify really quickly. I think everyone on the line is already tuned in and knows exactly what you're talking about. But for clarification, it is the ESO product that is being phased out. And we want to make sure we're exploring all options for trauma registry products and systems moving forward.
Correct. Yes. Yeah. So we're just looking at what would best fit our needs as a state. And so we really want to get your feedback. And some of the questions on the survey are just that. What kind of things do you think are most important when looking at a registry software? So we're looking at that when we're looking at all of the options that we have available to us.
Carissa and Chief Garcia, it may be helpful too for those that are not as familiar to have a little bit of that background. ESO basically acquired the top 3 registry systems in the nation. That was Lancet Trauma One, which we have, CDM, which is trauma-based, and then DI, which is Digital Innovations, otherwise known as NTRACS and a few other names for those of us who have been around for centuries. The only other product that right now is on the market for hospital-based trauma registry programs is Image Trend. I have some familiarity with that and know that from an EMS perspective, it's probably seen as a good program. It is less than ideal for hospital-based programs. So I just ask that we be very thoughtful and purposeful moving forward, that stakeholders are involved in this decision because this is going to impact our data at a local level for many more things in terms of submission, research, and other items that we are currently processing and collecting. So thank you for the work and the future work that's going to go into this. I'm sure it will be worthwhile with a lot of comments.
Yes, thank you for sharing that, Vicki.
Yeah, and in addition to what Rachel and Chris have said in regards to our implementation timeline, we'll be doing some major upgrades in 2023, and there's more exciting information to come on that in future staff meetings. And as we already talked about, as many of you already know, Trauma One will be phased out in the next 3 to 5 years. So our bureau is taking a proactive approach and making plans for this transition now. So that's our plan.
Thank you, Travis.
Rachel, one more time. In our recent discussions too, Vicki brought up an important consideration, and that one of the discussions we had in the last trauma program managers work group meeting was really around funding as well. And so if there are any considerations for as we move forward and look at trauma registry options, certainly the department will be exploring any infrastructure grant funding that is available, and longer term, any input you have in terms of data systems that work for your program, as well as, long-term sustainability, that is what we will be looking at here. And so thank you in advance for any feedback that you all can provide, because as you know, this is a very important topic as well.
I would also like to encourage any trauma program managers or medical directors on this call, if you're not already involved and on ESO's emails, they have a lot of town halls that they're currently offering right now where they're reviewing what this proposal of a new system is. And I believe Image Trend is doing the same thing. So if you're unfamiliar with either of the two, I would encourage you to go on to those town halls to hear about what these updates are going to look like. So that way all of us stakeholders are making the best and most informed decision.
Thank you, Kara. All right, any further discussion before we move on? All right, thank you. And again, that link has been shared. If you have not responded to the survey, please take a few minutes to answer some of those questions. Next on the agenda, any requests for agenda items to be considered for the next meeting? Dr. Foster did join. Unfortunately, we were in the middle of our discussion on the ACS field triage updates, and he was not able to stay. So we will add his item to the agenda for the next meeting. Any further agenda items to be discussed? You can always send those to either myself or Shelley for consideration. Next is a call to the public. Next, there is a summary of current events. You will see 3 events listed for the upcoming June month. I know Dr. Tang wanted to mention the Southwest Regional Trauma Conference. Dr. Tang?
Yeah, thank you, Dr. Bradley. I just want to let people know that we're running this year will be the 31st year Southwest Regional Trauma Conference. And it's held in Tucson on June 30th to July 1st. And it's a 2-day conference. It's totally trauma dedicated. The audience is largely geared towards, or the conference is largely geared towards EMS and also in-hospital staff such as nursing and techs. We give CME for the attendees. As the conference is not really targeted towards physicians, although there are certainly components that would be engaging for physicians. So, you know, and since that's not the intended audience, we're not really providing CMEs for physicians, but we're certainly providing CME for everyone else. You know, traditionally, it's been about 500 or so attendees from our southwest region of the country. It's a great conference. Again, it's on June 30th to July 1st. A couple other things. We have like 3 out-of-town speakers who are nationally recognized surgeons, and all with EMS engagements and backgrounds. And then we chose them purposely for that purpose. There are group rates as well. So I'll put the website in the chat room, but please, if you can advertise it to the personnel that you encounter who you think would be benefited by this conference, would be much appreciated. Thank you so much for allowing me to talk about the conference.
Thank you, Andy. Our next scheduled meeting will be for September 15th at 9 a.m. We will likely get another schedule on the books as well to discuss further the ACS field triage. And if I can get a motion to adjourn.
Motion.
Thank you.
Second.
All right. Thank you very much. All right. The meeting is adjourned. Thank you for a great discussion today.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks, everybody.
Kelly, you did it.